Good morning, ladies and gentlemen. Thank you for invitation and giving me the opportunity to present our case report. The case report I would like to present is titled Transcatheter Therapeutic Coronary Embolization with Gelatin Sponge Particles as an ultima ratio treatment for iatrogenic coronary perforation. 80-year-old female was admitted to the Department of Cardiology due to chest discomfort and shortness of breath. She had a history of ischemic stroke and permanent pacemaker implantation and several comorbidities like diabetes, hypertension, and renal insufficiency, and persistent AF. Moreover, 5 years before the admission, she had experienced non-ST segment elevation myocardial infarction with similar clinical presentation. The coronary syndrome was treated with PCI of the right coronary artery with drug-eluting stent implantation. ECG of the patient revealed AF with ST segment depression in leads A1, AVL, V4, 5, and 6. The patient's on admission, the patient's troponin level was elevated and peaked in subsequent blood tests. And taking into account clinical status, ECG abnormalities, blood tests, the diagnosis of non-ST segment elevation myocardial infarction was established. We decided to perform a coronary angiography. However, the procedure was postponed until hemodynamic stabilization and warfarin discontinuation. The procedure was performed via right radial approach. Coronary angiography did not reveal any significant stenotic lesion in the left side of the coronary tree. However, the procedure revealed total occlusion of the previously stented right coronary artery. The artery was occluded shortly after its origin, with a long portion of diffuse in-stent restenosis. Maybe it's not clearly visible on this movie. We noticed a small trace of antegrade flow through the stented part of the vessel, and when we performed left coronary angiography, there was some flow to the distal part of the right coronary artery from the left side of the coronary tree. So we decided to make an attempt to recanalize right coronary artery in this patient. After initially we had problems with passing pilot 150 guide wire, but then the guide wire passed distally and got stuck in the distal portion of the stented part of the vessel. We decided to perform 2 predilatations with a sapphire balloon to improve flow to the distal vascular territory. Probably during predilatation, the guide wire was inadvertently positioned outside the arterial bed, and when we performed control contrast injection, we noticed blushing near the distal edge of the stent. We left the first guide wire was left in place, and we took second pilot 150 guide wire and passed it distally in order to find true lumen of the vessel. Pilot guide wire easily passed to the distal portion of the vessel with a very good torque response, so it was expected to be placed in the PDA. However, we did not have good flow, so we decided, and that was the crucial part of the, I think the biggest mistake during the procedure, we passed deflated balloon on the second guide wire, and after control contrast injections, we had type 3 coronary artery perforation. Without unnecessary delay, patient received anticoagulation reversal, and we performed long inflation up to 15-20 minutes using first Sapphire 15 mm balloon. We are not able to advance a balloon to the perforation site, so the balloon inflations were performed in the proximal to the perforation site. Then we took another balloon, 215 mm sequent balloon. Despite anticoagulation reversal and long inflations, we still had perforation, so we made a phone consultation with our interventional radiologist. And we took the following points into account. We had deteriorating clinical condition, patient with hypertension, advanced age, lack of on-site surgical backup. We had right coronary artery not suitable for CABG. Patient was not suitable for a stent graft delivery. We did not have any additional consumables like microcatheters, coils, or commercially available thrombogenic agents like thrombin or onyx system or gel. And we decided to embolize the whole coronary artery with the use of gelatin sponge particles. Embolization material was simply prepared by cutting gelatin sponge into small pieces. The movie was recorded in my kitchen, so during the procedure it was much faster, and the sponge was cut into much smaller pieces, around 1 mm. So first we cut it into small pieces. And then we put it into the syringe and stir it up with the mixture of normal saline and contrast dye. And then we intubated right coronary artery very deeply. We advanced catheter very deeply in order to prevent backflow of embolization material into the aorta. So we had a damping of the pressure tracings, and we administered 5 to 10 ml of this embolization material. I'm not sure why this movie doesn't work. We noticed gradual occlusion of the right coronary artery. That was after around 50 minutes. And then we had totally occluded right coronary artery with sealed perforation site. The patient's clinical condition improved. TTE revealed only slight pericardial effusion, no signs of cardiac tamponade. Patient did not require pericardiocentesis and was discharged after 10 days. Conclusion that can be drawn from this case report are as follows. Gelatin sponge is an effective thrombogenic agent for sealing CAP in very specific clinical circumstances. It's widely available, and its use does not require any technical skills expertise. In certain circumstances, it can be reasonable to administer it directly through a guiding catheter. And apart from previously published data describing its effectiveness in type 1 and type 2, it can be also effective as the last resort treatment in type 3 coronary artery perforation. As a method that results in total occlusion and iatrogenic myocardial infarction, it should be considered in patients with CTO when other embolization methods deemed ineffective or are not available. And with limited deliverability of the stent graft. So it's extraordinary case. Thank you.
That's great, and very nice demonstration how to create this gelatinous material. So that was perfectly done. Let me ask you. So before that approach was considered, you were able to wire the distal RCA somewhat freely, and looked like you were in the true lumen.
No, probably we were not in the true lumen. No.
Okay,
no.
I see.
Yeah,
I see.
I mean, it was supposed to be in the true lumen because it looked like in PDA. I mean, but when we passed the deflated balloon, probably we made a bigger hole.
I see.
In the perforation site, and so for sure we were outside the arterial bed.
Was there more attempts made to rewire and to try to get back into the true lumen?
No.
And then so that with the idea of finally, getting back into the lumen and then hopefully pre-dilating and putting covered stents in?
No, we didn't make such an attempt, and besides we thought that it's impossible to put stent graft there if we had problems with advancing small balloon into the perforation site, so we anticipated problems with it.
Yeah.
Yeah, if you're lucky though, if you are able to recross, sometimes you just pick up a different dissection flap because it looks like your pilot 150 led astray, like you said, and I don't know if it's a small branch, because those usually don't exit the coronary, although occasionally they do, but they give you such little feedback and because they're jacketed and lubricious. So I think it highlights the difficulties of and kind of the benefits of dual angiography, so that if you have a retrograde visualization, that you can use that to double check where you are before bringing a microcatheter, if that's available, to swap out for a workhorse wire, just so you have better tactile feel, because that's one of the issues there. But if you are in a small branch and you're able to knuckle or something to redirect down, sometimes you do pick up a different dissection flap, and then if you're able to just get a normal balloon, even ballooning across that can sometimes act as a good way to seal that, because with the prior stent, it probably would be difficult with the Jomed.
Just a quick question. Would you ever consider going back for this patient afterwards?
Previous data suggested that after injecting gelatin sponge, it's impossible to cross it. However, I was in Singapore on CTO course. There was a guy from Japan. As you know, they are perfect in opening CTOs. And they had a case when they had recanalization following gelatin sponge injection. So maybe it's possible. Or maybe it was extremely rare case.
Well, great.
Thank you.
Perfect case. Thank you so much. We have a couple of minutes. First of all, I want to thank all the presenters who did a terrific job. I think, we have a full room, and there's clear interest in seeing cases from around the world. And I would say it's always a little bit more difficult and challenging to present your own complications rather than successful cases. And so we should really congratulate the presenters. But these are the cases that I think we learn the most from. And all of us will or have had complications. And I think this forum is an extremely important for learning how to handle these kind of situations. So thank you all for presenting. Any last few minutes we have? Any questions from the audience? Now would be, we have a microphone in the middle, but this is a very informal venue, so please go ahead if there's any questions or anything you'd like to discuss. This perfect timing. Any last comments from the panel?
No, I just want to congratulate everybody for staying on time, including the moderator, helping us all. I mean, everybody was perfect. 5 minutes, and the layout was wonderful. So thank you all for presenting your cases, especially your complications, and sharing with us so we can all learn together.
Yeah, we're commonly saying that just because everything went well doesn't mean you did it right, and just because something went badly doesn't mean you did something wrong. And I think these are great cases that we all learn the most from. So thanks for sharing them.
All right. Thank you all.